Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School, and welcome back to another GI Common Concerns. I want to talk about fecal microbial transplant, FMT as we know it, and it's been so staggeringly effective in C. diff infections. What about other things that we think are dysbiotic? It makes sense if you have an abnormal biome and you can transplant normal in, maybe the normalcy would transfer and change that abnormal dysbiosis and mitigate disease response. We'd certainly see that with C. diff. Relapse rate in the FMT trials seems to be approximately 95% effective. So what about other areas that we think are microbial related? Let's start with inflammatory bowel disease. A couple of these studies I'm share with you are they're EPUB. They're not quite out, and they'll be out in the journals probably in the early 2025. But I wanted just to relate to you what is out there. And certainly, let's start with inflammatory bowel disease and Crohn's disease. This is a study that was done in 3 centers in Canada, and they were looking at the microbial transplant delivered by colonoscopy and then 7 weeks of capsule delivery. And this is something that was with the idea of a composite endpoint looking at clinical remission and endoscopic response at the end of 8 weeks. So initial transfer from the colonoscopy, 7 weeks of oral therapy, and then at 8 weeks assess. And then basically there was nobody in the transplant group, although the numbers are small, there was nobody in the transplant group that had responded to any of those parameters, one in the placebo group, and they declared it futility. So for FMT and Crohn's disease, probably the most recent data would suggest, no, that's not really where we're going. How about ulcerative colitis? Well, brilliant study in the methodology. This is admirable. It comes from Amsterdam, looking at the delivery of FMT and ulcerative colitis. And they looked at patients with moderate to severe colitis and basically then took the patients with a procurement of an autologous specimen, which they reinfused as part of the placebo group, versus the allogenic specimen, which was garnered from super donors. So they recognize that there are certain enterotypes in the bacterial microbiome that have been highly associated with ulcerative colitis. One is a Bacteroides 2 enterotype, so they excluded those patients and a couple other parameters. But they then deliver these as it relates to sigmoidoscopy on the initiation and then by enemas on weeks 1, 2, and 3. And their primary endpoint was steroid-free remission, and the secondary endpoints were clinical related. But at week 8, they met futility analysis. So 2/3 into the way of their study, they declared this is a futility, and it was not something to be pursued, so they canceled the trial, although it was brilliantly done. So do we stop with that? Well, probably, maybe we do a pause, but a meta-analysis, a systematic review coming out also in 2025 in clinical gastro and hepatology looks at the response rate, and it looks at 29 high-quality papers, and they break it out by FMT response, and where analysis included the biome. They found that high diversity at the biome, meaning that they had a broad array of bacteria, was more predictive of a response to FMT, and contrary to the low diversity, alpha diversity, was more predictive of a poor response. So maybe we're getting to a point where we look for more of a super donor, if you will, matching the donor and the recipient, but really that's where we are in inflammatory bowel disease. So something that we can't use universally, but still on the holding table as far as possible in the future. How about irritable bowel? Well, we think irritable bowel certainly has an infectious component, response to rifaximin and small intestinal and intestinal bacterial overgrowth. And now we have EMO or the methogenic overgrowth. Those things are responsive to antibiotics. Well, a composite meta-analysis of looking at 10 randomized trials that was just published also this year in 2024 looked at the response at time frame of 12, 24, and 52 weeks, and none of those made a difference as it relates to a significant improvement in irritable bowel, so probably not also effective there. Well, is there hope on the horizon? Well, why does it work for inflammatory bowel, not work for all these inflammatory conditions and irritable bowel syndrome, but it works so well for C. diff? Well, we think that the transplant, and truth to be known, we don't really know the absolute why C. diff it works so well, but it's likely related to bile acid metabolism. And it seems to be a primary to secondary bile acid degradation that changes the ability for C. diff germination and toxin formation and reversal of that with a transplant seems to make sense, and that seems to be durable as opposed to these other conditions so far. Does it mean that FMT doesn't work? Well, two interesting studies say that it works. Small studies, one coming from China looking at long haul and sleep impairment. This was looking at very interesting analysis using validated instruments of sleep. I published a lot in the sleep world, very qualified to comment on that, but nonetheless, they looked at a FMT group and a control group that didn't have any treatment, and they looked at this over a 12-week period, and lo and behold, there was a dramatic improvement in sleep in these patients that had significant insomnia. And they found there were alterations, particularly in one bacterial species called Gammager formicus, and this is something that is responsible for the regulation of menaquinol, and this is something that vitamin K2, this is something that is involved in energy activation and transfer in the brain, so it makes some sense that it would make sense in some improvement in sleep. So again, very limited study, not an RCT study, but it's just something to stay tuned on. We do know that there are variables on biome as it relates to certain pedigrees of response for post-COVID. One other that was very interesting and exciting was presented at the most recent liver meetings in November in San Diego from the AASLD. This was looking at patients with severe alcoholic hepatitis. They were eligible if they were ineligible for steroids, and they had alcohol within the last 30 days. Their discriminant score for Mandry's index was greater than 80. Remember, we start steroids in those patients around 34, or renal dysfunction, or antibiotics, or GI bleed, or severe comorbidities. These are the worst of the worst, and they were randomized then to receive FMT via nasal duodenal tube for 7 consecutive days. And lo and behold, they had a dramatic improvement in the active group and relate to MELD scores at 3 and 6 months, their Mandry index at 6 months, their Glasgow alcoholic hepatitis score at 6 months. Major improvement, highly statistically significant. Interestingly, too, hepatic encephalopathy risk reduction went from prevalence of or incidence of 40% to 6% in the active group, and alcoholic relapses. So they went back, their alcohol tendencies went down from 40 to 10%. So again, very limited study. Again, needs to have validation, but again, FMT may make sense. Better understanding of the recipient and the donor and the match, the integration. All these things I think are biomic related. We just need to figure out the puzzles and the bridges to cross to get some best mitigation strategies. So don't give up on FMT, but it's not for all. And do recognize that Open Biome is now closed for business as of the end of December, and the FDA has shut them down for administration, which leaves us with VOS and Rebiota. These are, again, not approved for severe or fulminant C. diff, so it leaves us a bit in the lurch, no pediatric indications. So I'm not quite sure where we go on this for the patients with C. diff, but just to be aware of those, and Open Biome has submitted their controlled trial as suggested by the FDA, but nonetheless, that will not be available as of the end of December 2024. So, Dr. David Johnson, FMT, don't give up on it, but lots to be learned. Thanks again for listening.